Radiopharmaceuticals. And I just want to give a brief introduction, and you guys can feel free to add. But I want to introduce Dr. Keese, Dr. Booth, and Dr. Tonk from various institutions. We have Hopkins, Intermountain Health, and Penn Medicine that will be giving a talk today on radiopharmaceuticals. So a special thank you to you all. But first up, I think we have Dr. Keese to start.
Well, thanks for inviting us, and I'm glad to see you all coming online. I am just going to start with a brief introduction to theranostics and some tips on how to become an authorized user. And some of this will overlap a bit with Dr. Booth and Dr. Tonk, and we share slides with each other, as you see. These are my disclosures, including clinical trial funding and some non-FDA approved uses of drugs. Next slide. So what is theranostics? So theranostics combines therapeutic with diagnostics. So the pairing of sorry, you can go back a slide.
Oh, did I go twice?
So it's the pairing of a diagnostic agent with the therapeutic agent, and typically the therapeutic isotopes are beta emitters or alpha emitters, and the diagnostic isotopes are usually putting off gamma emissions or positron emissions for SPECT or PET. And then some of the isotopes, like lutetium-177, are both diagnostic and therapeutic, so you can see them on a SPECT scan, and they emit beta emitters. They emit beta particles for therapy. So one of the confusing things about this space is that there are many names for it. So don't get confused. All of these things are referring to theranostics, so targeted radionuclide therapy, radiopharmaceutical therapy, radioligand therapy. Peptide receptor radiotherapy is a little bit more narrow, and targeted molecular radiotherapy. So in general, it's the delivery of radionuclides, most commonly for the treatment of cancer, but also can be used for other pathologic conditions. Next slide.
Sorry, are my slides advancing? Oh,
Okay. So these are the most common agents that are currently in standard use in the United States. There's many others that are in development or in use commonly or previously in other countries. But the most likely for you to see right now in the United States in your training include radium-223, and this targets bone hydroxyapatite. So it's a mimetic of calcium. So it's taken up in areas of bone turnover. And then it is itself an alpha particle emitter. So radium itself, radium-223, is both the targeting moiety and the therapeutic moiety. So very simple, elegant drug. It's given in a syringe once every month for up to 6 cycles. For metastatic prostate cancer, it has been studied in other cancers, but is currently only FDA approved for metastatic prostate cancer bone metastases. Next slide. So another agent that is commonly used is lutetium-177 dotatate. This is a beta emitter targeting the somatostatin receptor for neuroendocrine cancers, and it is FDA approved for gut neuroendocrine cancers, and it has essentially, it's a small molecule that is binds to the somatostatin receptor and given intravenously along with amino acids to protect the kidney, and it's drawn into the cell. It's given through an infusion over several hours, once every 8 weeks for 4 cycles. So the next is lutetium PSMA-617. So this is used to be given mostly by infusion, but now is given as a syringe injection that is ready to use. It is also the same isotope, a beta emitter lutetium-177, targeting prostate-specific membrane antigen for metastatic prostate cancer. It targets the extracellular component of the transmembrane protein PSMA, and then again is drawn into the cell. It does not have to be given with any co-administered drugs, so that's why it can be just given as a push and is given once every 6 weeks for up to 6 cycles. And radioactive iodine has been in use for decades. This is like the original theranostic agent. It's given orally, and it targets through the sodium iodide symporter. The thyroid follicles can be given for hyperthyroidism or for thyroid cancer. And it was, introduced back in the 1950s. And next slide. Finally, this one is not a parenteral drug. It's given through the liver arterial distribution. It's yttrium-90 microspheres. There's theraspheres and ceraspheres. Yttrium-90 is a beta emitter, and these are not molecularly targeted, but they're injected through the liver arterial blood supply, and based on their size, lodge into the microcapillaries of the tumor and then deliver radiation locally. And this for liver tumors only. Next slide. So in addition to these agents that are in common current clinical use in the United States, a lot of the excitement in this arena is over the really large number of agents that are in development and are in clinical trials right now. There's over 450 clinical trials in theranostics ongoing right now. And this is a study published by my mentor, George Skoros, a review article just showing the publications increasing over the decades and across many different disease sites. Next slide. This is a slide courtesy of Dr. Tonk, showing a lot of the drugs in development, with the inner target being FDA approved drugs, and then the outer circles moving from phase 1 to phase 2 to phase 3. And you can see that there are many, many companies involved now, industry sponsors of the trials. There are multiple different types of drugs, beta emitters, alpha emitters, and different targets. This is a market analysis that also is courtesy of Dr. Tonk, showing that the projected market for therapeutic drugs in the US in billions of dollars on the left is expected to rise dramatically over the next 10 years and beyond. And that the current capacity for treating with these drugs in the United States is not quite capable of meeting that need. So that's the red dotted line at the bottom. Next slide. And then these current trials span many different cancer types. Basically, there are drugs in development for all major categories and disease sites. Next slide. So this leads us to, why we're here today in the ROVER series, the evolving role of radiation oncology and radiopharmaceutical therapies. So in the United States in particular, there's expected increasing demand and a shortage of radiopharmaceutical therapy workforce, both on the physician side and on our other allied health professionals, like technologists, nurses, physicists, and a shortage of clinical trial investigators. We also bring, I think, a longitudinal patient care value and our own scientific and clinical perspective to join with the perspective of nuclear medicine and radiology in this field, as well as medical oncology. And all of this leads to a need for more education and training of our residents and faculty. Next slide. So in particular in the United States, there's around 3,700 active nuclear medicine physicians, but there's only 81 current on-duty residents in nuclear medicine and about 19 for dual certification. There are many pathways toward nuclear medicine board certification in the United States, so it's a little bit confusing to kind of understand compared to the one pathway for radiation oncology. But next slide. In radiation oncology, there are about 4,800 active rad-onc physicians in the US, but many are not yet authorized users. And we have about 10 times as many residents on duty in the United States in our field. So in the community, there's a large number of increasing users of theranostics in the radiation oncology community workforce. So there's actually more radiation oncologists delivering radiopharmaceutical therapies in private practice or community-based systems than in academic systems. Next slide. Most of the patients that I see, I again follow along throughout their care continuum for prostate cancer. So this is a patient who had SBRT to the rib and skull base, and then a year later was treated with Pluvicto, and then later on in the disease course was treated with radium-223 and also palliative radiation, which isn't even on here too. So, is part of our longitudinal patient care and brings a lot of value. So for education and training, things are evolving rapidly in our field, and we are doing our best to try to keep up. Next slide. So one of the challenges for residents and junior faculty is obtaining authorized user status through the alternate pathway. So this requires us to keep NRC-related training records, and specifically the NRC 313 form, which is the federal form that for unsealed source use. And most of the states in the United States actually are agreement states where the state actually has their own authority to grant authorized users. And basically, a lot of the forms are very similar to the NRC 313 form, but depending on which state you're going to work in, it might be slightly different. So what we have advised the residents and their training programs is to compile the training records either in the form of a filled 313A form or a similar documentation that is signed by the program director and authorized user that's supervising. And then many programs are also considering obtaining authorized user status for their senior residents, which makes it much simpler for them to subsequently obtain authorized usership in their job positions, and no matter what state they're in. Next slide. So I'm not going to take the time to go through all of this form today, but I'll give you some links to some presentations where we go through this form in excruciating detail. But in general, this is the form that we're referring to, the 313A form for authorized users of unsealed sources. And we recommend that you seek authorization for the broader use of 35.300. Next slide. And under that you document training and experience under the broader training and experience of 35.390, which includes all the different categories of therapeutic isotopes. So you have to document your classroom and laboratory experience, and some of this will be standardized according to your residency program's curriculum. Next slide. And then other things, this will be important to document and experience the time in the hot lab or radiopharmaceutical or radiopharmacy, specifically spending time with medical physics. So there are going to be some likely changes coming through the ACGME soon. I know that we are all dealing with a lot of changes in sort of case log requirements and curriculum structures related to the last major round of ACGME changes, but they are considering an increase in the parenteral case requirement from 5 to 10, requiring 2 different agents in order to increase the quality and extent of training in residency programs for radiopharmaceutical therapies and meet the need in the country for increased authorized users, and to also be more specific about the training in activity quantification and radiation safety. So these changes have not been adopted yet. They've been proposed. Next slide. So here's the link to the different recorded sessions and webinars that have the very detailed NRC 313A form instructions. Next slide. And here are some more links also about other education resources that are specifically available to residents. So one is the Beyond the Beam course, which is available through Astro Academy for $99 for trainees, and many residency programs reimburse for that. Next slide. That includes a lot of the different topics that are not necessarily covered in your routine radiation oncology curriculum, specifically a lot of physics, dosimetry, principles of molecular imaging, chemistry and radiobiology of radiopharmaceuticals. Next slide. And then specific considerations for the agents that are currently FDA approved that we mentioned. Next slide. And there's also RPT training centers coming soon. One of them will be at Dr. Booth's center. So that will be very helpful, I think, for people who are out in practice who need to gain some experience before they can become authorized users. And then also there's some Astro learning collaboratives that are starting right now, one on starting new service lines and one on starting clinical trials. And we hope that many of you will join in on these education opportunities. And I believe that's my last slide. And we might have a couple minutes if there are any questions that have come in through the chat, or if people um,
I don't see
want
any
to.
questions in the chat yet, but no, it was a great talk, especially as a graduating resident. I think a lot of the PGY5 residents in the nation are trying to think about becoming an authorized user. So I think that's extremely important for us. If you're becoming an authorized user through residency, it doesn't matter if you go to another state to practice, correct? You just become an authorized user.
So it makes the form simplified. So that very first page of the form, there's like a checkbox to
Hmm.
say that you like have been an authorized user before, and then you uh, essentially it's it's easier, faster and easier.
Gotcha.
So you still have to become an authorized user at each individual location that you're at. Like I'm actually an authorized user here where I'm sitting and in downtown and in DC, at the
Oh, I
three.
see.
So you have to be added to your radioactive materials license for each location that you're going to administer. And then, the state, there's authorized users on each radioactive materials license, and it's all governed for us through the Maryland Department of Energy, but each state is slightly different in how they govern it. And then some locations have what's called a broad scope license, where they manage the authorized users at the institution. We have that at our main campus at Hopkins, and then other others have a limited license. So the place I'm sitting now is out in the county, and it's a standalone center, and we have a limited license here. It's not the broad scope license. So each individual authorized user has to be added at the state level, which takes like forever.
Gotcha.
6 months.
Yeah.
Yeah.
We have a few questions in the chat, real quick. I think Mo, your question may be answered in either Dr. Booth or Dr. Tong's presentation as well, but it was other than prostate cancer, what other cancers radiopharmaceuticals is used? So I think that may be
Yeah.
acknowledged.
So
Um,
thyroid cancer, neuroendocrine cancers are current uses, and then liver-directed therapy, so liver metastases. And then up and coming though is like basically every kind of cancer. There's like clinical trials ongoing in almost every cancer type. And then do you have to renew AU status after a certain number of years? I don't have a quick answer to that. So basically, um, you become an authorized user at your current institution, and then if you open a new location or you move to a new job, then you have to become an authorized user again in that those each new practice that you're practicing in. But like I don't believe I've had to renew, authorize, you just said, the radioactive materials license for each site does have to be often revised and renewed. It's more often revised because every time we add a new drug or anything or new trial, we have to revise our radioactive materials license. So it's not so much that it's like running out of uh, eligibility. It's just that there's a lot of modifications required on the radioactive materials license.
Awesome. Thank you, Dr. Case. That was great. So I guess next up we have Dr. Booth who will be presenting.
Wonderful. Thank you. I'm Dustin Booth. I'm a radiation oncologist, Intermountain Health, Utah Cancer Specialist. I help run the radiopharm programs in a hospital system in Intermountain Health, which spans 7 states, and then also in this freestanding center, Utah Cancer Specialists. And I'm really excited. Thank you for inviting me. This is kind of a full circle moment as of yesterday for me because Ryan Hutton, who's involved in the organization of this, was one of our residents. University of Utah residents rotate through here, and he texted me to bother me about my slides. And that's like, I'm sure a very validating and exciting moment for him to bother his father, his former attending there. So well done, Ryan Hutton. Okay. All right, so we're going to talk about PSMA-directed radiopharmaceutical therapy. I do have some disclosures. The one of pertinence is Novartis. I've done some work for them, and I will be talking about one of their products, but I'll try to remember to always use not the brand name, but just kind of the generic lutetium PSMA. So this is a different schematic of the one that Neil and Anna have. So I'm not going to go into great detail here, but what I want to point out is the largest piece of this pie. So every one of these different slices of the pie is a different agent. And it goes in the center from phase 3, 2, 1, and preclinical in the outer rind there. But the largest slice of this pie and the greatest amount of work being done in the radiopharmaceutical space is with this target prostate-specific membrane antigen. And then I asked, so this is done by Nucleus Radiopharma, their CDMO, and I asked them to make a modification and to look at just the ones that could have GU oncology applicability. So let's go to the next slide. So in the dark blue are all the potential prostate targets. And it's a little misleading because, PSMA started with prostate, but if you really look into it, it's neither prostate, only or specific, even though it's prostate specific membrane antigen. You have also SSTR2/3 or 3, which is predominantly for neuroendocrine, but there's work looking at it for dedifferentiation neuroendocrine prostate cancer. In the dark blue, this is all the prostate stuff and the potential prostate stuff. And then you have in the purple, you have the urothelial targets, so bladder cancer, and in yellow is the renal targets. And again, there's some crossover, like FAP is a pan tumor, but what I'm trying to point out here is like if you're going to GU oncology, you have a GU oncology practice, is that you could have a large number of these agents. This could change everything to what you do and how you do it in the next 5-10 years. So it's very applicable, but we're going to focus on the biggest slice of the pie, the most work that's being done with PSMAs. So I'm not going to hash this out because I know Anna just went through this, but this is a protein, a transmembrane protein that's being targeted, overexpressed in tumor cells. And it's this catalytic domain that the ligands, either it's 617 or INT or J591, that'll bind to this. And then a little bit more into the mechanism of action. We can go to the next slide. So this is the mechanism of action of either the therapeutic PSMA directed or the radiologic. So what happens, you have binding of this extracellular domain, it's endocytosed, it's brought into cytoplasm of the cell. And if it's the diagnostic side, there's a gamma emission. So think F18, gallium-68, that's being read and the images are being produced. But if it's the beta emission, if you attach a lutetium-177 radionuclide, then you're getting beta emission, you're getting larger molecules that are delivering lethal blows to the DNA. That's the schematic from this paper. It's a little misleading because it's showing a double strand break when really this is a beta on alpha, and you're seeing mostly single strand breaks unless it's an alpha. But that's the basic mechanism of action when we're thinking about PSMA. So this is a great slide that was done by Jeremy Calais, who was nice enough to share this with me. So what I want you to do is look towards the bottom of this slide. At the bottom of the slide is this orienting us through the journey of stages of prostate cancer. So we're going from hormone sensitive all the way to first, second, third, fourth line of castrate resistance. So from diagnosis of localized disease to the end of the road. And each one of these different columns is a different stage. So localized disease, first on the left, then like biochemical recurrence after definitive treatment. And then we get into the hormone sensitive, once it becomes metastatic, and then first, second, third, and fourth line. So that's kind of the middle section there. And then now look towards the top of these different boxes that have these different study names. These are the different studies that are being done in the radiopharmaceutical space. And where it all started is that when I have that extra purple kind of surrounding that box, and in big caps is vision. So this is the vision trial, and we're going to go through that. But I want to walk you through the journey of gathering data, getting more and more data in the GU space. But it started in the second line, MCRPC, castrate-resistant prostate cancer, after chemotherapy. But you can see there's a huge effort being done in this space, a lot of trials and a lot of data. So let's go ahead and go through it, and let's start with the vision trial. So this is the landmark study, New England Journal 2022 or 2021. Looking at the use of lutetium-177 PSMA or lutetium PSMA for prostate cancer in this setting. So this is important because this has applicability in my practice. When you're in the community, you're getting lots of consults for this. You really need to know the indication and what the study showed. And so eligible patients were patients who have castrate-resistant disease. I've received referrals from patients that have hormone-sensitive disease. And I've had to turn and say, hey, you can't get this, we can't get this therapy until they actually have progression. PSA is going up on Lupron, plus or minus an ARPI. So they have to be castrate resistant. And they've had to have already seen an ARPI. Sometimes patients are older and not everybody gets an ARPI. Most people do, but sometimes you see people on just Lupron. And then also one or two taxane regimens, that's docetaxel or cabazitaxel are the predominant ones that are being used. And so this is post-chemotherapy, but the other thing you really have to know is this lighter blue box here, and this is the PET qualifications for treatment. So somebody asks you, hey, like what on a PET has to make so that you can treat these patients? Well, you have to have PSMA positive disease. I've received referrals, and I don't know if this happens at Penn or Hopkins, but certainly in the community, I've just had one a month ago that somebody had a oligometastatic disease, was treated, underwent Lupron, and was controlled for many years, had kind of this really slow growing cancer, and then had SBRT to a couple spots. And then they referred the patient to me once the PSA continued to rise. But guess what? They had no PSMA avid disease anywhere because the SBRT took care of those 2 or 3 spots. So I couldn't treat them, right? So that's important to know, is that you need to know what that means. And what positive means is that you have gallium uptake greater than the liver. And I hope that in your time in residency, you're learning how to determine SUVs and whatever packs that you're using, and determining, okay, what is the SUV of the liver? And then going into those bone lesions, go through those exercises of determining it and working with your nuclear medicine physicians. Teach yourself that because it'll be helpful. And then there's no PSMA negative metastatic lesions. And this is important too, because you're going to see patients with heterogeneous disease, right? These are patients that have sclerotic mets that may not be avid. Well, that didn't keep patients out of these trials. It was bones with soft tissue component. Okay, solid organ disease, lymph nodes that were large that were not avid. That's what kept people out of these trials. You can have heterogeneity of expression. You can have sclerotic disease in bones that you assume that is dead. And there's all sorts of nuances with use of FDG and things like that. But I wanted to spend some time on that. That was the qualification for the vision trial. Let's go on to the next slide. So we're going to look at some Kaplan-Meier curves here and just bust through a few of these here. Because I think we're already moving through time. So really looking at the vision trial, PFS benefit of about 5 months, a little more than that. And that was in patients that received the PSMA 617 versus standard care. Something to, let's go to the next slide, please, and look at the OS. And this trial, importantly, showed an OS benefit. And it was only 4 months, and that may not be something to really, write home about. But the truth is that if you look at these patients, and there's criticism about the standard care arm in this trial, and we could go into that if we had more time. But these patients, the way I look at it is like they're kind of the same. If you had a GBM patients, they've got about a year to live, right? And so this added an additional 4 months to that stage of disease. And it was significant, and that led to the FDA approval of it in this setting. But it did more than that. Let's go to the next slide here. So that not only did it improve OS from 11 to 15 months, but it also helped people feel better. And I saw this just last week. So I had a patient that received 1 cycle of Pluvicto. Their PSA bumped a little bit, and they were just not doing well after 1 cycle. And ultimately decided just, hey, let's get, I almost always give 2 cycles. Let's give the second cycle. But sure enough, they give the second cycle, and he had kind of diffuse pain everywhere. He had radiation twice to his hip. And I saw him in follow-up, and he's doing way better. He's doing great. So certainly, and as I'll show you in a quick case, external beam can benefit these people up front, but sometimes you can just start them on the drug. What's the adverse events, the grades? So fatigue is super common, 43 versus 23%. Xerostomia, honestly, it's there, but I find that if you don't ask most patients about it, they won't even tell you about it. But I've had a couple of patients that have had a really bad xerostomia over the years, but not a lot. But it's something to counsel patients about and to continually to look into your patients. Diarrhea can happen, thrombocytopenia, really any cytopenias. And there's also kidney toxicity, although that's quite uncommon, I think because we're underdosing patients. So that's the VISION trial. Now let's move a little bit earlier. Okay, now first line MCRPC. And that's the main trial that came out as the PSMA-4 trial. And we won't spend a ton of time on these trials, but I did want to show that the PSMA-4 trial, it is upfront in CRPC. So these patients are pre-chemotherapy. They don't have to have had chemotherapy before. So let's go to that next slide. That showed a PFS benefit as well as no OS benefit in this setting. There was significant crossover, which means that eventually a lot of people got this, the drug anyways. But there was a benefit of PFS 5.5 versus 11.6, basically 5.6 versus 11.6 months, about 6 months benefit. But there was, I want to say 50-60% crossover. So this led to the FDA approving it in the next line setting. And then the next trial that's being done, we have some data on it, is the PSMA addition trial. Now this is the hormone sensitive. So this is patients been diagnosed with metastatic prostate cancer for the first time, have not seen Lupron significantly for their metastatic disease. Maybe they saw it at BCR, maybe they saw it at high risk with external beam. But let's go next slide and look at that one. So back a slide. There we go. So primary endpoint was met so far. What that's looked like is a difference of PFS that we're still, we don't even have enough data to look at the median rPFS, but the hazard ratio is 0.72, p-value is 0.002. You can see that the curves are separating. Why don't they separate earlier? Well, this is hormone sensitive disease. People in general, Lupron will keep people, under control for 2 to 3 years, right? So I think those curves will continue to separate. But this is also a population you need to think about long-term toxicity. You need to think about these patients differently. We need to look at them and study them because they're living, sometimes five more years, right? So, but that is currently, this is the early data. This has not been FDA approved for this setting, but this was presented at ESMO. Next is the LUNAR trial. I love this trial. This is Astro. If you guys went to Astro or read it, this is super exciting to me. This is in the also in the MHSPC setting, but in the oligometastatic setting. So let's take a look at that data real quick. So what's cool about this study is patients have oligometastatic disease, 1 to 5 lesions, and they randomized to either just getting SBRT to those lesions or neoadjuvant 2 cycles of a PSMA-directed radiopharmaceutical therapy or lutetium PSMA. It was PN2002, which is not 617, and there's a story behind that. But essentially, they did the SBRT in the one arm, then they did neoadjuvant. in the other with radiopharmaceutical therapy, and then did SBRT to all of the remaining PSMA PET defined disease, which again, I love this interplay between radiopharm and external beam. And what it shows, and remember, these patients are not getting Lupron, right? They're not getting it. They're just getting radiation in one form or another. And what did it show? It showed a PFS benefit of 10 months, hormone-free survival of also 10 months. That number, that first number, is pretty interesting, that these patients who are diagnosed with metastatic disease went 2 years without touching Lupron. For those of you who've gone through G rotation, you know that patients really struggle with that drug often. So exciting data for sure. Okay, so now a quick case. So this is a 68-year-old gentleman presenting with metastatic cancer. And he was actually sent to you because he had some pain in his lumbar, thoracic lumbar spine area prior to getting started chemo. Okay. And so he had this lower back pain. MRI showed some enhancing lesion. PSA was elevated back in 2022. He started on, had involvement in multiple bones. He started on Lupron. But then earlier this year, PSA started to creep. 0.5 in July, then 1.8, then 2.8. And then, so the patient states he has this 3 out of 10 pain in the middle, lower left part of his back. Doesn't have any paresthesia, there's no central anesthesia, nothing like too bad. And he's like, you know what, it's actually, when I saw my medical oncologist, it was 6 out of 10. But, I just rested for a few days and it's really just 3 out of 10 and all I'm taking is Tylenol. And physical exams notable for tender palpation in the thoracic lumbar region, kind of middle lower back. So next steps. So what do you want to do next with this patient? Well, the first thing you want to do is you want to call either the referring neurologist or medical oncologist prior to the consult and just say, hey, I believe you've got this rising PSA. I know you're doing chemo. What do you think about a PSMA PET? For multiple reasons, but what do you think about radiopharm? We just had a new indication that's in the first line CRPC. And so medical oncologist said, hey, well, is there any data to support that? And you share this data, Vision PSMA-4 trials, and they agree to get a PSMA PET. So let's go to the next slide. So what does it show? It shows multiple areas of metastatic disease, but there's this large retroperitoneal lymphadenopathy. It's like 5.2 by 3 centimeters, but the PSMA SUV max lesion is between 12 and 15. The SUV of the liver is like 8. Okay, so important to look at everything, but the SUVs are high. Is this patient a candidate for treatment? Well, we got at least one PSMA positive metastatic lesion that has PSMA avidity above the liver, and there's no PSMA negative lesions. And there's one other thing that's in PSMA-4 criteria about prostate lesions that should be PSMA positive. He doesn't have a prostate. We're good. Okay, so what do you recommend? Well, 2 scenarios here. In this patient, he's like 3 out of 10 pain, controlled with Tylenol. I would just start him, right? We could add external beam radiation, but there's a good chance, we learned from these trials, that they're going to have an improvement in their bone pain. But let's say it's 8 out of 10 pain, poorly controlled on oxycodone, and you're in an area where it takes a while to get Pluvicto. In the early days, we were waiting months, and so I was doing a ton of radiation up front, just trying to keep people from crumping on me before I was able to get the drug because it was in such a short supply. A little bit of bonus round, and feel free to chime in, Neil and Anna here. So this is where there's not a ton of data, but everybody's trying to figure it out. You get 6 cycles of lutetium PSMA every 6 weeks. Now, this patient had a 28.4 PSA. It went down to almost nothing after cycle 1 and was undetectable after cycle 2. We did a SPECT, and that's another topic in and of itself. We did SPECT, and this is what it showed. So that same super avid mass, it's half as big, and there's no avidity, and all the bone mets, there's no avidity anywhere. What do you do? Anna, Neil, putting you on the spot.
Hold treatment until progression. So I have a patient who just did this, and He actually was off treatment for 10 months before he had to come back on treatment. So he was going to Nashville, country music concerts, and enjoying life off therapy.
Yes, I agree. The book answer is to keep on going. That's the book answer. But the modern approach would be there's no target anymore. And you can keep on giving this patient drug, but all he's doing is peeing it out. So I would also hold treatment, let him live, and then treat at progression.
Yeah, at this point, because you can see what you treat, what we're seeing is kidney and parotid. So your drug is going to kidney and the parotid and not really cancer, and it's undetectable PSA. This is a cool part of doing these medicines, you guys. You get to use the imaging to make your decisions, and you get to think it out about it in a very specific way about where you're treating. And I have a patient that's 16 months that is in this exact same scenario. We're out of time. I'll just blow through the next one. The next one is just you had a patient, same patient, but then PSA started to go up on you, and so you do you do a PSMA PET scan because your hospital administrator says, hey, if it's progressing, we could do a drug and then a SPECT, which will cost $53,000, or do a PSMA PET, which will cost us $3,000. So we do that. We do a PET scan, and everything's resolved except for this one area in the posterior elements of L3. Okay. Well, yes, thank you. But what would you guys do in that scenario? So you got a tumor, you got only progression in one area.
Beam on.
Beam on, yeah. So you get to use the other side of your brain, right? Neil, is that what
Yeah.
do you think you do that too?
SBRT, enjoy watching the PSA go down and let him live.
Yep, and keep going, right? And so this is a great paradigm to be able to use as a radiation oncologist. You get to use your external beam. You get to use this new systemic therapy. You get to think about it in a really interesting way. And thanks for letting me share a little bit about it. All right, now Neil, go.
All right. Well, thank you, everybody. It's a really good group, and I appreciate you all listening in. I'm going to wax poetic for a second before I get into my talk. Radiopharmaceutical therapy and the ability as a resident to be comfortable and competent and excellent in delivering these treatments going into practice is currently, in my opinion, the hottest thing for new graduates. 15 years ago, it was could you do SBRT? You know, 5 to 10 years ago, it was could you do space OAR? Now, every single one of our graduates is being asked, can you do radiopharmaceutical therapy? And in the spirit of training, residency time is the best time to learn this in a comprehensive fashion, make mistakes with this, learn from it, and then roll into a practice and start excelling at it. So, congratulations on tuning in, but really by the time you graduate, this should be a common thing. I'll go to the next slide. I forgot to put in my disclosure slide. There's a number of companies that I consult for of research grants with, but none that will be discussed that's non-public information. Let's go to the current landscape. Next slide, and one more. So I apologize. I wrote Dr. Hertz's name incorrectly. It's Hertz. Saul Hertz is the founder, or essentially the godfather of theranostic treatment, and at Massachusetts General Hospital in 1941 administered the first amounts of therapeutic iodine for the treatment of hyperthyroidism. And that was published in a 29 patient series with later with 5-year follow-up in the New England Journal of Medicine, and really revolutionized systemic radiotherapy as a form of treatment. And thyroid treatment with radioactive iodine has not gone away. Unfortunately, it contracts a little bit due to the reimbursement landscape, but it's a very satisfying patient population to treat. It's outside of the wheelhouse of normal radiation oncology, but it's very, very satisfying when you can look at a patient and tell them you can cure them, cure their Graves or other hyperthyroidism, or work with their thyroid cancer. There's a number of, this is a list of all of the FDA-approved theranostic agents that have ever been approved. The most common of which Dr. Keese had reviewed, which is sodium iodide 131, lutetium dotatate, Lutathera, radium 223, Xofigo, lutetium PSMA, Pluvicto. And those are the most common ones that are used. There's a number that were approved and have since been withdrawn from the market due to low use or more effective therapies replacing them. But treatments have been all around the body already. Next slide. And these are the remaining ones. So Dr. Keys had previewed this slide, but I do want to point some facts to this and a little bit more context. That red dashed line represents the current healthcare system radioligand therapy capacity, a flat line. And this was when this slide came out a few years ago. And you'll see starting in the mid 2020s exponential growth for both diagnostic as well as therapeutic, which is medications like Pluvicto and Lutathera. So this massive, massive growth. And if you take an even broader view of it, two FDA-approved drugs, Pluvicto and Lutathera, generate sales of $5 billion and $1 billion expected for 2025 per year and have already outspent the Medicare spending for radiotherapy services, for external beam radiotherapy services. So this is already a sector, if you're just using Medicare spending, two drugs have surpassed that. Now, granted, these two drugs are about one-fifth the size of pembrolizumab, but there is massive, massive opportunity to be involved, and this is the exact right time to do it. Next slide, please. And we'll keep on going. One more. So now we'll dive into some novel agents. So Dr. Keese had briefly touched upon this, that theranostics is a modular platform. You can take any radioactive compound, or really there's a select few that are important. You have to attach it to something using a linker, use a targeting molecule that could be an antibody, minibody, peptide, or small molecule. That complex attaches to a target protein that's on a cancer cell or a non-cancer cell, for example, in cancer-associated fibroblasts. But this is a completely modular platform. This is very similar to, say, antibody drug conjugates. And then you can target a number of things that are cancer cell targets, tumor microenvironment targets, but also viral, fungal, and bacterial targets. And there is increasing amounts of study for cancer applications, directly targeting cancer cells, targeting the tumor microenvironment, so targeting the environment around cancer cells, and then also targeting bacterial, viral, and fungal targets. For example, we have a program that uh, studies bacterial proliferation using a diagnostic version of Bactrim. So there's lots of different ways that these theranostic agents are developed, and the sky is essentially the limit in terms of what can be designed. Next slide. There's a pathway to developing these theranostic agents, and it's a relatively straightforward drug development pathway once you kind of have half the know. And if any of you, as trainees, have the opportunity to take a full year in lab, I would recommend that you do so if you're interested in preclinical and early phase work, and it can really accelerate your career in this space. I know Dr. Keese and I have both done that thing with time in lab during residency. But the first in vitro analysis starts with target expression analysis, cell uptake studies, viability, and classic clinogenic survival assays, and then serum stability assessment, seeing if this drug will just live. And then once you move into um, treatment models, animal model selection, model-specific considerations, imaging and therapy, biodistribution, you got to see where the drug went, and then survival analysis in mice. And then that'll go onwards into first in human. The trial portfolio is massive. There's over 200 trials, probably closer to 300 now. For global theranostics, lutetium-177 dominates, but there's rapidly increasing trials in actinium-225, I-131, lead-212, and thorium. Next slide. And then even though GU dominates the space, um, uh, there are a number of other cancers that are being studied, and not only is it tumor specific, but also target specific. So pan-cancer theranostics or disease agnostic um, uh, disease agnostic agents. Next slide. In the global therapy and diagnostic portfolio, the bulk is dominated by positron emissions, which is diagnostic radiopharmaceuticals, but again, hundreds of therapeutic trials are underway. Next slide. And then these are some select novel RT trials that are across different tumor types, somatostatin receptors, bombesin receptors, FAP, HER2, CCK2, and others. So let's focus on a couple specific ones that are of particular interest that you may hear about sooner rather than later. The GRPR, the gastrin-releasing peptide receptor, is expressed in multiple human cancers, including ER-positive breast cancer, PSMA-negative prostate cancer, primary brain tumors, and then multiple midgut tumors. And then in several early phase studies, the GRPR receptor can be imaged, but can also be drugged. So not only can you use this for detecting prostate cancer or breast cancer or brain tumors in another fashion, but you can also drug them. In this example on the right, the MR image shows on the top right a single lesion that's probably in the anterior prostate, anterior left prostate that matches to the GRPR PET scan, and then same thing on the low image, a GRPR PET CT, and then the PET-only component. So the GRPR is currently being studied in pancreatic tumors, breast cancer, prostate cancer, and brain tumors. Really just an exciting field. We'll go to the next slide as well. The next exciting thing to think about is how do we make these agents agnostic of the disease? Fibroblast activation protein, or FAP or FAP, is a surface antigen that's expressed on CAFs, or cancer-associated fibroblasts, which are part of the tumor microenvironment for nearly all human cancers and virtually absent in all normal tissue. It's a pan-cancer imaging agent, theranostic. Historically, there have been challenges with what we call washout or retention, meaning that the drug didn't sit there long enough for it to kill enough tumor. And then next generation agents are maximizing drug delivery by increasing retention, and therefore you can deliver therapeutic doses. But this has been unbelievably exciting. There's multiple trials for different tumor types underway, including gastric cancers, pancreatic adenocarcinomas, liver, colorectal cancer, cervix cancer, and breast cancer for FAP. We'll go to the next slide. Um, we'll go to novel alpha emitters next. Thank you. Next. So there's the differences between beta emitters and alpha emitters. Beta emitters have a wide distribution of energies, low recoil energy, causing single strand breaks. Key particles include lutetium, iodine-131, and copper-67. And they have a relatively long range across multiple cell lengths. So they can irradiate both target as well as nearby cellular tissue, nearby cancer tissues. Alpha emitters, on the other hand, have a short energy distribution, high recoil energy, cause lethal DNA double-strand breaks. They're represented by astatine, lead, radium, actinium, and thorium. And then they only go across very short distances, maybe 1 or 2 cell lengths. Next slide. So there's potential advantages in that alpha-emitting radionuclides could cause more lethal damage in a smaller amount of disease, leading to less radiation of normal tissue. But there's also less recoil and crossfire effect. So there's advantages and disadvantages, but it's an incredibly exciting, incredibly lethal way to kill cancer. Next slide. This is an example of the in vivo path length of a beta emitter versus an alpha emitter. So the squiggly white line shows what the path length of a beta emission might be, but the straight red lines show what the relatively small distances an alpha emitter would travel, suggesting really it's not going to go that far. Next slide. So again, some higher LET advantages, limited range normal tissue, more practical shielding and release requirements. For example, patients drugged with alpha emitters generally don't require special shielding. A piece of paper can stop many of these emissions, and lower administered activities. The challenges, though, are for alpha emitters, limited range normal tissue, so it may not be great for big tumors or tumors that are poorly vascularized. Production and transportation are tricky. Unpredictable daughter isotopes I'll mention in a second, which lead to potentially higher, less predictable off-target toxicity. And like Dr. Booth had mentioned, less SPECT imaging can be used to see what happens after each administration and quantify the doses, but SPECT imaging for alpha emitters is emerging. Next slide. There's a tremendous amount of power of alpha. The Warmth Act study was a multi-institutional, multinational collaboration of men, of featuring male patients who received treatments with actinium-225 PSMA radioligand therapy, median of 2 cycles, mostly on compassionate use, and about a third had prior radioligand therapy with PSMA or radium. And patients that were heavily pretreated, a median overall survival of 16 months was achieved, which is unbelievable for a very sick, very advanced population. But about two-thirds experienced xerostomia or dry mouth after 1 cycle, suggesting some more off-target toxicity. Next slide. These daughter isotopes can offer off-target toxicity. On the left is an alpha emitter with a targeting vector and a target site, and then the daughter radionuclide comes off, but separately than the alpha particle, but the daughter radionuclide itself may be lethal. Next slide. So there's these elegant decay pathways where in some types of alpha emitters, you may generate 4 lethal daughter isotopes, leading to some unpredictable features. Next slide. In terms of radionuclide status for alphas, radium-223 is FDA approved, actinium-225 and lead-212 are in production in industry, but not FDA approved. There's going to be several of these agents probably approved in the next few years. It's going to still take some time. And then other molecules like terbium and thorium are coming up. Next slide. There are some challenges. There's a limited global supply of this. In this example, this shows what continents are capable of producing which alpha particles. For example, excuse me, Australia is capable of producing lead but doesn't have any actinium manufacturing. North America can produce most all of it. Europe can produce most all of it, but it's a limited global supply and coordination of production is important. The PRISMAP project in Europe has been instrumental for actinium production, and the U.S. Department of Energy Consortium has been instrumental in creating actinium networks here. Next slide. These are a number of alpha trials that are in development and are opened. We have several of these open at Penn, and we are opening more. Next slide. So the global theranostic landscape has a robust trial pipeline. The novel targets can expand indications or be tumor agnostic, and alpha emitters offer advantages for specific applications. The future could be cocktail theranostic combinations, alpha beta combinations, theranostics with or without external beam or drugs, pre-targeting, and novel administration methods such as direct tumor injection, or there's a concept being bounced around right now about direct bladder installation of some of these drugs. And radiation oncologists, especially those that seek AU status and ability, are poised to be a robust portion of the RPT future. Thank you.
Thank you, Dr. Tong. Well, thank you all of the panelists, for a great talk. I had a quick question. As a graduating resident or even, young attendings who are trying to, implement, these new therapies and even getting referrals for these new indications for, prostate cancer patients earlier on in their journey. Um, what have your techniques been in terms of, getting the patient volumes and getting these patients?
I'll go briefly, but I think Dr. Booth or Dr. Keese may have some more program building insights. These drugs are proliferating rapidly, and a substantial population of American households live close enough, but not quite close enough to receiving these. So there's still a lot of opportunity to grow these practices. First, I would suggest before you start trying to build a practice, you have to see if the practice is viable. You won't be able to get a drug and start a program really without support of some degree of administrators and maybe your P&T committees. So you have to get some degree of buy-in and maybe develop a preliminary concept of a business plan such that you can justify creating a program because it does cost requires some resources. But once you kind of get that infrastructure, I think can grow organically, but you also have to be present at tumor boards, maybe a bit patient facing even. So I invite the other panelists to offer some more insight.
Yeah, sure. I can. So on the community side of things, you need to know where your referrals are coming for and who's doing what. So in some settings, you have urology practices, lung put type practices that do a lot of the advanced prostate stuff themselves. And so right now, when it's in the castrate-resistant setting and it's pre-chemotherapy, we're seeing a shift in the way these patients are coming to us and to other authorized users. And previously, when it's post-chemotherapy, that referral pipeline is coming after medical oncology often. And so most of the referrals were coming from them. And so building relationships with your medical oncologists were important. It still is, because some of these patients are also seen by them, but it really just depends on the community where you're going to practice. Urologists, they may be doing that in-house, or they may be referring it out, or maybe they're not even doing it at all. So you have an opportunity to educate them and share with them about your practice, and know that when it's first-line castrate-resistant prostate cancer, they can refer to you. So it's really, every community is going to be a little bit different. Practice patterns are going to be a little bit different when you start your practice. If it is in the community, just understanding how patients flow and how they're being treated, and get to know people, and gradually build your practice.
Yeah, I agree too. It's like keeping communication with the referring providers on a patient-to-patient basis, like builds the trust and then gives you opportunities to educate, like without being like heavy-handed, you know? So like if you see a patient being referred to you from a physician and it's like post-chemo and they're like they could have gotten it earlier when they had a better functional status, you know, you can just say, hey, we're starting treatment on this patient next week. By the way, it's now FDA approved for pre-chemo, you know? So just like opportunities to reach out and communicate with your referring providers is the best way to build practice.